Okay, here we go. All right. Thank you for that. All right. So like I said, this is a presentation I came across a few years ago. It really is, I think, one of the better explanations of trauma and trauma-informed care. But it does focus on this population, which is okay because we've wanted to have one of these populations, cancer, HIV patients, as an example of one of the groups anyway, so that's all right. So after this presentation, you'll be able to, define trauma and what trauma-informed approaches are, recognize the signs of trauma, describe the impact of trauma on the body and brain, and understand the impact of trauma on people living with HIV. Now, so this is an example. If you want to think about it, the information that you're about to hear is really stuff that you would present in a psychosocial group with people who have experienced some type of trauma in a specific group. This very much definitely would be used with people who have trauma from HIV. So think about how you would present this in a group setting, but also get your clients to open up and process what they've gone through. So, all right. So let's start though with what is trauma. An individual trauma results, and I'll just read this, from an event, series of events, or set of circumstances experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on the individual's function and mental, physical, social, emotional, and spiritual well-being. And yes, trauma can impact our relationships, and we can get into some examples of that as we move along. Actually, I'll give an example of how trauma can affect relationships. I worked quite a few adult rape cases where before the rape, it was a stranger rape situation where the female, and it was always female, was in a what would seem a very healthy, normal, functioning, intimate relationship. In a couple of cases, they'd been married for 5-10 years. In one case, they'd been married for over 25 years. But the rape occurs, and because of that trauma and that rape, most men, and in the cases I worked, all of them, in fact, there's a statistic to it, 88% of men will leave their wife within 12 months of having a stranger rape occur. Okay, I want you to think about that when we're thinking about how trauma impacts relationships. And then we see people who go through chronic trauma, and they're constantly in and out of relationships and constantly, and it has that effect. And I just wanted to make everyone aware of that, because especially if you go into the field of sexual assault and whatnot, recovery plan should always include family members, especially if there was a functional, healthy relationship before the event occurred. And that's part of the role we can play as social service providers in trying to reduce those negative impacts, especially in relationship situations. So this is just a kind of a graph of the definition, where we know that trauma has so many influences, but also so many points of resiliency. If you think about this continuum of, you have the individual who's experiencing a trauma, they have relationships with family, friends, intimate partners, children, and then we have the community at that broader end, and then the societal end. And each one of these areas can be a place of resiliency that can help a person recover. But each of these places can also be a source of trauma and continued trauma that we have to address in the group and treatment setting. So what do I mean by that? Resiliency, we know that if there's a strong parent-child bond, if we know that the child is in a consistent home, is cared for, we know that any type of trauma, they'll most likely be able to get through without any major setbacks. And if we have a supportive community, we know the same. And then society as a whole, if it supports that role, can also be a source of resiliency. Where probably, especially in dealing with individuals who have had trauma, and probably a good example is again going back to sexual assault, right? In that society and communities tend to place a lot of the blame on the victim, and that becomes re-traumatizing. And then within intimate relationships and family relationships, families start to, again, question, well, why were you there? Why did you put yourself there in the first place? It must be what's wrong with you. And there's a couple reasons we need to understand this dynamic of victim blaming, because it's actually a coping mechanisms for those who have been close to the traumatized person, especially when it comes to parents and intimate partners and close siblings, is that you're so blended, you're genetically together, you're all those things, and you have to create a separation, a mental separation between, can that happen to me, or did it happen to brother, sister because of something brother, sister did? And it's that protective mechanism within relationships and communities that kind of make this victim blaming kind of thrive, is because they have to create this mental distance, because no one wants to think that they could potentially be in that same chair as that individual. And I know that seems kind of a strange way of thinking and processing, but when we look at the victim blaming literature, that's basically what it's telling us, is that we have to get rid of that barrier that victimization happens because of some quality of the individual. So we don't have to do this mental escape and can actually support victims completely. And we also know within lots of communities of color, LGBTQ, we know within the indigenous communities that trauma has a higher burden to it. Because society amps up the blame for those traumas that have occurred. And in a lot of ways, if we go to the indigenous Native American experience, society really created a lot of the trauma that they've experienced over the last 400 or 500 years. So we see that as a clear example. And within the literature, we start talking about historical trauma and those types of inherited traumas that people have. And we should note that everybody has inherited traumas. It's just the amount of trauma that certain groups have experienced outweigh the traumas that other groups have experienced. And again, we go back to the Native American experience. There was so much trauma created in such a short period of time. We're talking 400 or 500 years. And that condensed amount is enough to create a historical and continued trauma within these groups. And it doesn't help that society and communities exacerbate the problem through things like denial and things like, oh, it's because that's the way they are, those types of things. So I guess my point right here is that trauma is a complex problem. You have the individual who's traumatized. You have those who are close to him who are trying to figure it out in their own head, whether they could be traumatized or not, or maybe they're the cause of it. We have then a societal and community stereotypes is, I think, a good term for people who have gone through trauma and then are suffering because of it. And so this kind of provides a framework where you can talk to your group about how each of these levels of life have influenced them and their trauma experience. And this is an important part of trauma recovery and working in a group setting. Is it's going to be individualized for each one of your clients, even if they have the same trauma. For example, in this one, it's HIV, right? Despite having the same traumas, it will always be experienced differently by each individual. And that's why it's important to process each one of these levels so that people can come to understand their resiliency factors, things that will help them get over it, and those things that will hold them back. It's kind of like that relapse prevention example. There's the mines and there's the safe places. And that's what you kind of want to do with this kind of looking at each level of where trauma occurs. Okay. So this is some of the questions that need to be asked when a person has experienced trauma or has trauma symptoms. Is the underlying question is, what happened to you? As I just stated, and it's very important to state, trauma may look the same from individual to individual, but it's experienced differently by each one of them. And that simple question, what happened to you, validates that individual, okay? What are called behavioral health symptoms that may be adaptations to traumatic events. Behaviors have meaning and purpose. Healing happens in a relationship. And I want to go back to this second point. What are called behavioral health symptoms that may be adaptations to traumatic events? And we've taught some very clear examples of this is post-traumatic stress disorder, right? There you go, a full-blown disorder because of past trauma. But we also know that abnormally high drinking can be a sign of trauma. I'll give a good example. Again, I'll go back to the sexual assault field, is that victims, and this is a generalization. Remember, everybody is an individual and is different, but this is kind of a generalization. When sexual assaults occur, the behavioral symptoms of the individuals tends to become what you call a bipolar event, okay? Meaning that victims can become very hypersexual or very hyposexual to where they almost are disgusted by it. They can become very heavy drinkers, or they can go completely to abstention if drinking was involved in the traumatic event, or they might go to a complete excess of it. Relationships, either they become very disinterested in the relationship, or they become almost to a dependent disorder type of situation where they cling on to that person overly because of trauma. And so when we talk about behavioral health symptoms, what we're usually doing is taking normal adaptive behaviors and we're seeing if they adjust to the left or to the right. Do they become hypo, meaning they become non-existent, or do they become hyper, where it becomes almost in an excess of what would be normal for, you know, that individual within that, again, community, within that culture, within that family system. And so those are all things to kind of gauge. And it's also important to give your clients permission to understand that they have symptoms. So when they're experiencing those extremes, they don't feel like they're crazy, because they're not. They're just having a response to trauma, okay? They're trying to manage it. And that's where it becomes behaviors have meaning and they have purpose. And that's a very important statement after that behavior statement. And then this is the most important thing that I think, especially for this class: healing happens in a relationships. All right. You'll have your group there. that's a system of relationships and a system of support. But one of the things that we need to do within the group process is build up other relationships for that client. Again, I go back to the example of intimate partners and leaving, right? So we have to help focus on developing and building those relationships. And one of the things you want help your clients do is to avoid isolation, because that makes the trauma symptoms worse. I know that sounds counterintuitive, especially if the trauma was due to some social behavior such as rape or car accident or something like that. I know that sounds strange. Let's push them back into people. But in essence, that's kind of what we want to do, because that is the healing part of it. That's where the healing is going to occur. It's not going to occur in an isolated space. All right. This video I don't think works. Well, let's take a look.
If you're an Arizona homeowner, 2022 is your last chance to go solar.
All right. We'll look at empathy here in just a little while. I want to go on for right now. So now, talking about trauma, how should it be approached? One is experiences from our past influence our current behavior. That's a given, right? If, how, and when a person chooses to talk about life experiences is completely a personal one. Some may not label what happened to them as a trauma. They might just say, you know, that just happened, and they'll go through that. You know, one thing to think about when a person goes through trauma is they also go through loss. And if you remember kind of the model of the grief model, one of the grief recovery places is denial, denying that the trauma occurred or that it's called a trauma in the first place. Beware of words you use, and no other words may be different. And I think this is important in our field, because we use a lot of words that are common use words that may have a different definition dependent upon the audience you're speaking to. And to me, the way I try to alleviate this in the group setting is I usually come up with a lot of common words that are used, for example, within the trauma area or that, and I provide the definition that I'm using in that group. And I explain to my group members, I want you to read through this, because when I say something like emotions, this is the definition I'm using, because we all have a common notion of what emotions are, but we all probably have a slightly different definition. And so that's one of the tools that I use to help with group members, so that we stay on the same page and use the same language, so no one goes away confused. So in the group setting, we want to know, how do the clients define trauma? What other words do you or those with whom you work use to describe experience that could be called traumatic? And this is kind of the beginning phases of understanding, again, the subjective view of your client, okay? And then we want to explore what are called the 3 E's: event, experience, effects. Events or circumstances that cause trauma. Experience, it differs from individual to individual. So some people, I'll give a really good example. I think I've given this example in some of my other classes. When I was the crisis shelter manager, at the same time, I had 2 different clients in my shelter, and for one, I had one client who had been brutally beaten over a 2-week period, raped several times, and just had a lot of horrific things. She was in the hospital for about 4 to 6 weeks before she could even come to the shelter because of all the damage that had been done. And then I had another client at the same time who had been physically abused by her husband. The police got her out, but she had absolutely had no resources. Her husband is actually fairly wealthy, but she didn't work. She didn't do anything. And so in this experience, you know, we go through the trauma, we go through the 3Es, we do the assessment and all that kind of stuff. And the woman who was severely hurt over a 2-week period had no trauma symptoms whatsoever. She was just doing life. She was making life happen. She seemed to have this level of resiliency that it just didn't affect her. However, the other individual, she could get her toenail broken and could go in completely trauma existence and completely decompensate in her behaviors. And you think about that, you know, okay, yes, no matter what, abuse is abuse. In this situation, though, if you were to ask in the general population, which one of these individuals experience most trauma and are probably going to have the most issues, you'd probably pick the young lady that was in the hospital for 4 to 6 weeks because of it, right? But the truth is that trauma, again, going back to this experience part, is individually experienced and it's individually processed. And some people are resilient to large amounts of trauma, whereas we kind of have the same response when the trauma doesn't seem like it's warranted for its reaction. And that's why we got to keep this on the individual level and make it so we create a safe space where no matter what society would say the trauma was and how they should be experiencing, they're allowed to process it at their level and at their way without being judged. And that's an important term. Judgment is not a good thing in this setting. So the effects can be broad and disguised as symptoms or behaviors. And this is important again, you know. I'll go back to the example. Was the first young lady I described, was she trauma-free? And my answer would be no, because her fingernails were always bleeding because she was always picking at them. And so there was obviously some response to something going on. Usually that's a sign of high anxiety, high stress. And so, but it's experienced very individually, right? And so we want to look at the events, experience, effects, and always need to take it from the client's perspective, okay? And when we're talking about trauma, we should list at least, you know, what we're talking about. There's different types. We have abuse, emotional, sexual, physical, witnessing violence, death, loss, abandonment, natural disaster, chronic stressors such as prejudice, disability, racism, invasive medical procedures, all those kinds of things are all things that can create trauma and really have an effect on the brain itself. I will bring up, you know, when we talk about witnessing violence and whatnot, it's kind of an interesting thing when we look at post-traumatic rates. And we can go back to 9/11 as an example, all right? And it would be assumed that the highest rates of PTSD that we would see at 9/11 were individuals who were at ground zero, that they were the ones that we were going to see rates higher than that 17% that I described a couple weeks ago, that's the average after a trauma. And we expected it to be at the combat rate around 30, 40, 50%, somewhere around there. But it was interesting that that's not what we actually found. We actually found this kind of halo around ground zero, this circle that was about 100 miles out from ground zero. And that's where we saw the highest rates of PTSD symptoms after 9/11, is people who were close enough to be directly affected, but far away enough that there was a sense of helplessness, that they couldn't do anything. And that research led to other research. For example, within the military system, we find that the individuals that are at highest risks of developing PTSD are drone drivers, people who attack from a distance. So even aircraft flight people, they don't even see their targets anymore, really. We find that that's where we're seeing the highest concentration of PTSD. It's not necessarily the guys and gals who are just on the ground directly confronting the enemy. It tends to be the individuals who indirectly confronted the enemies that we're seeing the highest rates of PTSD. So this kind of fits within the witnessing violence type situation, because you see it, but there's not much you can do about it. So it does a dual thing to the individual. One, you go, that could have happened to me, and it is happening to me. Two, I feel helpless because there's nothing I can do to help or fix the situation. And that tends to be a condition of that puts people at higher risks of having trauma symptoms due to acts of terrorism or violence. And so, and we find that this to be true. There's a halo that sits around natural disasters. There's halos that sit around even human-caused disasters. Like I said, 9/11 is a good example of that. So those are kind of some things to kind of think about. Experience and trauma affect by how, when, where, and how often. And again, I'm going to say this has to be an individual level. And so how is the method? When is the time it occurred in that person's history? And that's an important statement to say when we're talking about when a traumatic event occurs, is the amount of trauma that's going to be experienced. It really also depends on where the person is in their head, in their life, in their situation. If they have a healthy relationships, they have decent job, all those things, trauma is going to have a lessening effect. But the more life stressors we enter, such as instability in relationships, instability in work, instability in housing, all of those have a compounding effect when trauma occurs. Where and how often? So how often is it chronic? Is it something that continues over and over and over and over time? And we do know chronic trauma does have a longer, not intense level of trauma symptoms, but a longer negative effect of trauma symptoms than acute types of trauma. Okay. And where, I'll go back to where, because I think this is important. Where, if it happens within the person's intimate environment, such as their home, it's going to have a longer lasting effect than if it happens, for example, with a car accident or something like that. So the where also plays an important role, because if that person frequents that place, they're going to have triggers, just like someone dealing with addiction, and they come across things that trigger them in their environment, and they can go through those trauma responses. So those are all important things to consider when processing trauma with individuals. The effects of trauma on an individual can be conceptualized as an understandable response to painful situations and conditions. And that's something just to kind of keep in mind. These are natural responses that people have. All right. Trauma, and this is kind of psychosocial education part of a group, would be trauma can cause short or long-term effects. Affect coping responses, relationships, learning, and developmental tasks. We know, for example, individuals who experience severe physical or sexual abuse at a given age, and it has a trauma effect on them, that they actually get stuck in that age cognitively. Okay, meaning that, you know, a child who experienced severe trauma at the age of 12 tend to then remain in that cognitive knowledge state from there on out until some more healing takes place, more intervention takes place, and whatnot. So, you know, when we talk about uh, communities of need, especially, you know, underserved communities, we need to understand that part of the issue that trauma and everything creates in those situations is that cognitive slowing, and that we need to have not only treatment and mental health providers uh, on the front line of this, we also need educators on the front lines of this, because they're the ones that are going to be able to stimulate those brain processes and try to help prevent them from slowing down. It can affect a person's behavior and affect physiological responses and health, well-being, social relationships, and spiritual beliefs. Again, I'll go back again to experiences with individuals who were sexually assaulted with the spiritual beliefs. I saw where they either became completely devout in their religion, or they became completely atheist in their religion, just over a short period of time after a trauma occurred. And we know again from the grief literature, right, is that spiritual issue goes on in the grief process, where you get angry with your maker, you deny your maker, and then you start to negotiate with them to try and make things better. And the same thing happens here. Okay. All right. And these are kind of some of those issues that go along with trauma that we talked about earlier on those dynamics. Remember those dynamics of the individual, family, friends, relationships, community, and the society. Is the impact of trauma, and again, this is a generalization, tends to be worse in conditions where it occurs early, meaning earlier in age. That there's a lot of blaming and shaming within the social system, or there's being silence or not believing at all. All right. And that can have just as much an effect as shaming and blaming. And it's really important to state this. There's even disorders that develop due to the silencings of trauma in the family. We call it borderline personality disorder, which is a disorder where childhood traumas, sexual abuse traumas, all those types of things, that chaos that occurs in the family, get swept under the rug and never discussed. That creates a pattern of behavior, pattern of personality traits that is maladaptive. In fact, it looks a lot like bipolar disorder, where the individual starts to have success, and then there's a breaking point and they just spiral downwards. They'll, you know, lose their job, take off for weeks, over drink and over excess in drugs and sex and alcohol and all those types of things. And it's truly a self-sabotaging disorder in a lot of ways. And so being silent with trauma within a social system is just as bad as in a system where that trauma is blamed and shamed on the child, or maybe sometimes by this time the adult. Is a perpetrator a trusted caregiver? And this tends to get to kind of that social end that we've been talking about, right? Is that if the trusted caregiver is the one who created the trauma in the first place, it becomes more and more difficult to try and help that client get back into social relationships. And it becomes, they tend to isolate a lot more, and it hurts a lot more because they were trusted. Okay. All right, and this is just kind of an example of, when things happen early in childhood, there's this thing called the adverse child experience, and there's actually a measure of it, and it actually is very predictive of long-term health problems and social problems dependent upon the scoring of it. Okay, and it just basically states the more types of adverse childhood experiences, the more impact it has on our biology and our health risks, and the more impact it has on our future health and well-being and social health as well. And so the more trauma, the more biological issues and the more social psychological issues, which I don't think is surprising. It's interesting that it is to some, though. And this is kind of what the ACEs questions look like. So we'll go over these, and then we'll close up for today. Basically, it asks, when you were growing up during your first 18 years of life, did a parent or other adult in the household often or even often swear at, insult, put you down, humiliate, actions that made you afraid of being physically hurt? The second one is pushing, slapping. And then the third one, we get to at least 5 years or older, was there touching, fondling in a sexual way, oral, anal, or vaginal types of intercourse. And then the fourth one, we get a little bit even more. No one in your family loved you or thought you were important or special. And then 5 is, did you have enough to eat? Were your clothes always dirty? Was there a guardian, basically, a doctor in your life? And the 6th question is, were your parents ever divorced? And then we go into, was your mother or stepmother often or very pushy, grab? So we're getting to individuals, and then we get to drinking and alcohol problems. Then we get to mental health issues questions, and then questions about prison and those types of things. And the more and more that is listed, the higher and higher the ACE score goes. Okay, and that's kind of how this measurement works. So when you did a household member go to prison? Yes. How often? Well, they went, every year, it seemed like. Okay, that would be a high score on the scale. And this is really what that we're trying to get down to, is these are the things that are affected by the ACEs scores, and these things are what we call highly correlated with ACEs scores. And just kind of look at some of these things, that the effect of our childhood, like the higher our ACEs scores, the more likely we're to use alcohol or substance, smoking, early initiated smoking, early initiated sexual activity, multiple sexual partners, unintended pregnancy, adolescent pregnancy, risk for in the future violence is predicted by an ACEs score. And then health outcomes include things like depression, suicide attempts, fetal death, sexually transmitted infections, health-related quality issues, ischemic heart disease, liver disease, chronic obstructive pulmonary disease. And then there's social outcomes such as homelessness and incarceration. And again, I want to point this out. The higher this score is, the higher risk individuals are for these behaviors as adults. So a male child, and this is just an example, a male child with an ACEs score of 6 has a 4,600% increase in the likelihood of later becoming an IV drug user when compared to a male child with an ACEs score of 0. Might heroin be used to relieve the profound anguish dating back to childhood experience? Might it be the best coping device that an individual can find? And I think in this class, I've mentioned studies where I did in the prison system, where we found that women about 80% of the women in this prison were sexually assaulted in some way before their criminal acts started. And we found a lot of the criminal acts were coping mechanisms. So they were, drug use, theft, stealing, all those things that would help relieve what we would call trauma symptoms. And, back to those studies, as I believe I mentioned in here before, we started to treat the trauma and the recidivism rate went way down in this population. And so again, this idea, what if we focus on the trauma instead of the actual IV drug use? And I wonder in our broader society, if instead of just focusing on the consequences such as addiction and whatnot, what if we actually started focusing on the primary cause of those? It's just an interesting thought experiment. We then see that we also see that a person with the score of 0 has an average lifespan of 80, whereas a child or a person with a score of 6+, it cuts off about 20 years on average based on just childhood trauma. All right. We're going to end with this, with just a note on resiliency for today, and then we'll pick this topic up again on Monday. Resiliency is defined as the ability of an individual, family, or community to cope with adversities and trauma and adapt to challenges or change. Resiliency is promoted in part by a supportive relationships and social connectedness, as well as addressing sources of adversity. I want to take that second bullet point because this really comes down to what you do in the group setting. You provide a supportive relationship. You provide the opportunity to socially connect, and you don't avoid talking about the adversities. You challenge them and you make them come to life so that people can start to heal from their trauma instead of being trapped by their trauma. All right. But we need to talk more about resiliency as we move forward. But we only have about 15 minutes and this is going to take a little bit longer. So I'm going to stop sharing for right now. And I'm just going to open the floor. Does anybody have any questions about the content of today? All right. Mira, to answer your question, the scale for the ACEs is 0 to 10. And usually we see people who score above a 6 as the highest risk. People who score between a 3 to 6, there is the association between negative outcomes and the ACEs scores become less. When you get down to 0, you could probably guess that there's no association, but that's kind of how that scale works. Rhonda, yes, some people do the ACEs as part of a suicide ideation evaluation. It can be very useful for individuals who can't identify this sounds strange, but there are individuals who commit suicide or try to or attempt suicide without having any knowledge or understanding that that is what they're doing. And so sometimes the ACEs score is to kind of bring to light, hey, you're killing yourself here, and here's your risk factors that you really maybe should take into considerations. And then a lot of times it's also used in the follow-up to suicide ideations and attempts after the person has gone through the crisis. A lot of times counselors and therapists will use the ACEs scores to bring to light, this the reasons why people might be going through suicidal ideation. But very good question, and that's I hope that answered it. Any other questions for today? Oh, good. All right, everyone. Well, let's close down for today, because I just think the content that we have will take longer than the 15 minutes we have today. So let's go ahead and shut down about 15 minutes early, and we will see you all on Monday. I look forward to reading your reflections. Take care, everyone.
Thank you.